I decided just to record the parts of the lecture that I did not go over in class. For one thing, I was listening to the lecture and I was really sick at the time, so it's awful. So I'm just going to record the parts that we didn't cover in class and hit some high points. With vitamins and minerals, of course, we all need those. It's best to get the vitamins and minerals that you need from the food that you eat. Of course, there is fat-soluble and water-soluble vitamins and minerals. The water-soluble vitamins can be dissolved in water and easily excreted. The fat-soluble are dissolvable in fat and they're stored longer in the liver and the fatty tissues. The water-soluble are your B complex and vitamin C, and they are not stored as long in the body, and we can get deficiencies more easily with those. The fat solubles are your A, D, E, and K, and we usually don't have to take those daily. However, there is really almost an epidemic of vitamin D deficiency, and I don't know if that's just because we just aren't getting enough sun now or what, but there's a lot of research now being linked to vitamin D deficiency and disease processes. So get plenty of vitamin D. A, D, E, and K, again, are fat solubles. These are in plants and animal foods. We store them primarily in the liver. They're a little bit slower to metabolize and break down. They come out through the feces. They can reach toxic levels if we have too much, and so big thing with kiddos, they take too many vitamins, especially because vitamins look like candy. You know, we get our Flintstone vitamins. They can get hypervitaminosis. Vitamin A helps with night vision and for normal vision, so this helps with retinal pigments. Vitamin D is called the sunshine vitamin. Also helps with calcium and phosphorus in our body, so if they're low on calcium and phosphorus, we'll add vitamin D. So that's really important with osteoporosis when we start talking about that too. Alpha, beta, gamma, and delta make up vitamin E compounds, and that's the active and natural form that comes from plant and animal sources. Vitamin K is very important to the liver and to those coag factors 2, 7, 9, and 10, and the clotting factors. 2 is for prothrombin, and 7 is proconvertin, and 9 is the Christmas factor, and then 10 is the Stewart-Prower factor. Normal serum levels are 0.1 to 2.20 nanograms per milliliter on vitamin K. And then typically if people are low on vitamin K, we give vitamin K injections. So it's a very thick injection to give, and we do give it intramuscularly. Vitamin B1 or thiamine deficiency can result in Wernicke's encephalopathy. So think of this one a lot with alcoholics. If patients come into the hospital and they drink a lot, we might have to give them a banana bag. It looks like Mountain Dew. And they need that thiamine because their body lacks it. I'm not asking you to remember the normal serum level from 70 to 180 here, but I am asking you to think about people that lack vitamin B1 as having this Wernicke's encephalopathy. It can happen with brain lesions. It affects the peripheral nerves. They can have cardiac changes. It can also be caused from poor diet or really bad fever or hyperthyroidism, but it's more typical with liver disease and alcoholism and malabsorption. And so we will give patients B1 to help with that. They get into delirium tremors, also known as DTs, if they don't get enough B1. Niacin we have talked about before, that's vitamin B3. It's indicated for the prevention and treatment of pellagra, which is caused by the deficiency of B3. and that's a result of malabsorption. We can treat hyperlipidemia with it. We've talked about that before, but it would take really large amounts of niacin to treat that. It can also treat peripheral vascular disease. One of the main side effects of niacin is facial flushing. Vitamin B6 a deficiency of that can lead to a certain type of anemia and neurologic disturbances. Seborrheic dermatitis, chelosis, which causes kind of like cuts around the mouth, and it can result in convulsions, especially in neonates and infants if they don't have enough vitamin B6, and a type of anemia, and a glossitis, which is like a shiny tongue, and stomatitis, which is the sores in the mouth. It can affect the peripheral nerves, the skin, the mucous membranes. It can cause all of these conditions if somebody is lacking this water-soluble vitamin B6. Can be a result of uremia with the kidneys, can be a result of alcoholism, liver cirrhosis, hyperthyroidism, malabsorption syndromes, and heart failure. Also certain drugs like TB drugs and hydralazine for blood pressure. Hopefully you have heard of vitamin B12. This is a very important water-soluble B-complex vitamin that is required, and if you have vitamin B12 deficiency, you have a malabsorption issue that is known as pernicious anemia, and we would have to give you B12 shots for the rest of your life. And that is also a thick IM injection that patients would need to get. If not treated, it can lead to megablastic anemia, and that would cause irreversible neurologic damage. Vitamin C is known as ascorbic acid, and we use that in many therapeutic situations. Does help prevent flus and colds, but you can get too much of a good thing. Prolonged vitamin C deficiency results in scurvy. We learned that many years ago, and that's characterized by weakness, edema, gingivitis, and bleeding gums, loss of teeth, anemia, subacute hemorrhaging, bone lesions, delayed healing of bones, and hardening of the leg muscles. So we need this for wound healing and collagen synthesis and the maintenance of connective tissue repair for our bones and our teeth and our capillaries, and for folic acid metabolism. And it's essential for erythropoiesis. It enhances how we absorb iron, so we've talked about that before too, that often if we're giving patients iron, we might try to give it in orange juice if it's a liquid iron. It is required for the synthesis of lipids and proteins and steroids, and it's been also shown to aid in cellular respiration and the resistance to infections. But if we give too much vitamin C, it can cause problems as well. And it can mix wrong with certain medications, so you have to be careful with any vitamins and minerals that we get just the right amount. We all need calcium, or we will have hypocalcemia. Causes of calcium deficiency is not enough intake if we don't have enough vitamin D to facilitate the absorption. Hypoparathyroidism, which is something that we will talk about later in patho. Malabsorption syndromes, especially in our older adult population. Things like infantile rickets or adult osteomalacia can cause problems with calcium deficiency. Osteoporosis, renal deficiency for sure causes calcium deficiency. Normal serum calcium levels should be between 9 and 10.5. Calcium helps us with nervous, muscular, skeletal muscles, and cell membrane and capillary permeability. Helps us with cardiac and smooth muscle and skeletal muscle and renal function, respiration, and blood coagulation. It's very important for neurotransmitters and hormones. Helps us with amino acids and gastrin secretion. Magnesium is also very important. Sometimes if somebody isn't holding on to their potassium levels, We need to give them magnesium to help with that too. It's one of the principal cations in the intracellular fluid. It's essential for energy metabolism. Hypomagnesemia is usually caused by malabsorption in the presence of high calcium intake. So this can happen with alcoholism. If somebody's getting a long-term IV feeding, if they're on diuretics, so again, that's where I've seen it, where we have somebody who has hypokalemia, and then we're giving them a K rider, but they're not holding on to their potassium, so then we might have to give them a little bit of a magnesium rider as well. Metabolic disorders including hyperthyroidism, DKA, or diabetic ketoacidosis. Symptoms associated with this disorder include cardiovascular disturbances, just like we would have with our hyper or hypokalemias, neuromuscular impairment, mental disturbances. Dietary intake will help prevent magnesium deficiencies. Phosphorus is in our foods, so dietary deficiencies are rare, but malabsorption disorders that cause diarrhea like IBS or vomiting or hyperthyroidism or hepatic disease or long-term use of aluminum and calcium antacids could cause phosphorus issues. Normal serum levels are between 2.8 and 4.2. I'm not really asking you to remember all of the lab values on these right now, but I am giving them to you. AF is a 35-year-old female patient. She underwent a partial gastrectomy because of a large gastric ulcer. She's seen by the physician today for follow-up. She's healing well, but complains of significant tiredness, numbness of the fingers, and her tongue looks different. Glossitis. The physician suspects pernicious anemia and orders a complete blood cell count, or a CBC, and a vitamin B12 serum level. AF's B12 level is 88, and the CBC shows that she's anemic. Vitamin B12 replacement is ordered. What do the nurse and the patient need to know? We need to know a lot about B12 because this is a common one that we give. What do we think is the most likely cause of the pernicious anemia? Well, we had part of that stomach removed, so we're missing the intrinsic factor now for absorption of vitamin B12. So we're going to have to understand the pathopart of that disorder, and we know that we're going to have to give some B12 now, probably for the rest of this patient's life. What's the most likely route that we're going to administer this? We're going to give it IM. We could do intranasal gel, but we are likely going to do IM injections. There is the sublingual B12, but it would be questioned with this patient because they don't have hardly any intrinsic factor, so it's just not going to be absorbed well for this patient. What patient teaching are we going to give them for adverse effects of vitamin B12 replacement? Well, we're going to talk to them that there is a risk factor of heart failure. There is a risk factor of vascular thrombosis and pulmonary edema and flushing. So we're going to have to tell them about what are the side effects of heart failure, what are the side effects of pulmonary edema, what are the side effects of a clot, optic nerve atrophy, so, side effects of going blind, diarrhea, itching, rash, pain at the injection site, which is a lot more likely. This itching and rash and pain at the injection site, those are a whole lot more likely than congestive heart failure with B12 injections. And then low potassium, hypokalemia. We need to let them know that they're going to need this for the rest of their life. And then we need to make sure that they understand the side effects so that they would know what to report to the provider. Most commonly, the side effects are rash, pain at injection site, and then low potassium. With osteoporosis, The Wicked Witch is being treated for calcium and vitamin D in order to slow the progression of the disease. She asks the nurse about the relationship of vitamin D and calcium absorption, and what teaching will the nurse provide. Well, we would tell her that she could get vitamin D from foods and supplements. She can also go out in the sun for like 10 minutes a day. That'd be good. It helps the body absorb the calcium and regulates those levels in the bones. We can find it in fish, such as salmon, canned sardines, and the sun. She asks why she developed osteoporosis, and we want to talk about the risk factors. Calcium deficiency is related to being white, having a small frame, having a sedentary lifestyle since Dorothy returned to Kansas. Causes of calcium deficiency include inadequate calcium intake, insufficient vitamin D, hypoparathyroidism, malabsorption syndromes. That's really popular in the older individual. Calcium deficiency related disorders with like infantile rickets or adult osteomalacia, muscle cramps, and osteoporosis in postmenopausal women. Not that men can't get it, but it is more common in postmenopausal women due to estrogen levels. And then renal dysfunction. So wrapping up, you want to know a little bit about antacids, over-the-counter antacids. You want to know about the H2 antagonists and what they're blocking. You want to know about H. pylori, and that usually, on average, patients are going to be on medications for 4 to 8 weeks, and there are different regimens, but it can include antibiotics, it can include Pepto-Bismol, it can include, let's see, am I thinking of anything else? I'm trying to think of all of this off the top of my head, but there's know your patient teaching for if patients are being tested for H. pylori and how we treat that, the bacteria for that with ulcers. Know with Carafate that sticks to the ulcer, and that know how you would give a Carafate slurry, and that it's given on an empty stomach, and that they need to take it either 2 hours before other medications or 2 hours after other medications because of the way it's absorbed. With Cistrodiprol or Cytotec, that one, the action of it is that it produces extra mucus, and so that one's how that one works. And then I've given you a lot on vitamins and minerals as well. Vitamin D, of course, is synthesized by the skin. If you have too much vitamin C, it can cause stones. It's a really great vitamin, but too much of anything is not a good thing. You have to know about the intrinsic factor and vitamin B12. Knowing your actions of your GERD medications. Trying to think of anything else that I need to include in your wrap-up, but definitely peek over your PowerPoint slides and go over your case studies before your quiz, and I will see you soon.